Well, leukemic stem cells are the real drivers of most hematopoietic malignancies. And since a few years, we also know that normal hematopoietic stem cells are the cell of origin of many leukemias and other hematopoietic malignancies. So we know, also in human, that indeed the first mutation happens in the hematopoietic stem cell, generating a clone, which we know as clonal hematopoiesis, which is in all of us to some degree, and it increases in size and number when you get older. And secondary mutations in some cells of this clone then actually lead to a full transformation into, for example, acute myeloid leukemia. Very importantly, those leukemic stem cells are key in resistance and development of relapse, because leukemic stem cells often show a number of features which make them resistant to current therapies. Leukemic stem cells have some features of normal stem cells. Normal stem cells often are in a deep quiescent or even dormancy phase. So basically they sleep, unless they are needed. In kinds of SOS situations, infection, inflammation, they wake up. But most of the time, they do sleep and are in a dormancy phase. So current therapies are anti-proliferative chemotherapies. So if you hit a dormant cell wouldn't care about anti-proliferative chemotherapy. And that's actually one of the features which make them resistant to standard chemotherapy. A second feature is that they also have developed ways to escape the immune system and recognition by the immune system. And that also allows them to basically restart the tumor after initially successful therapy, where most of the more differentiated blast cells, for example in CML or AML, are removed. The leukemic stem cells stay behind. Often that's only a few. They are dormant, but this dormancy is reversible, so sometimes they wake up and then they can actually start a relapse, and since they also are not recognized by the immune system, the tumor actually starts again. And that's also a way to target them. So one way would be, get them out of dormancy, then actually they are more susceptible to, for example, chemo. We have ways to activate receptors which make them recognizable again by the immune system. So there's a clinical trial which we're starting in Heidelberg soon, where we actually use an activator, which is a PARP inhibitor, which actually brings back recognition receptors on the surface. And then we transplant natural killer cells, and these natural killer cells can then recognize the leukemic stem cells and hopefully eliminate them all. And a third way is there is a revolution going on in AML therapy using, for example, venetoclax is a BCL2 inhibitor. BCL2 is an anti-apoptotic protein. And that and its family members, MCL1 and BCL-XL, are actually proteins leukemic stem cells are dependent on. And venetoclax, for example, very nicely eliminates leukemic stem cells, just not all. And so we are currently, or the field is working on making that more efficient and really target all of the leukemic stem cells using these kind of anti-apoptotic blockade of anti-apoptotic proteins. Regarding new targets, there are new technologies which is used to actually study human diseases, in particular looking at diagnosis, minimal residual disease and relapse, to identify not only leukemic stem cells but also the pathways which make them resistant and provide them with self-renewing activity. And these technologies are now based on single-cell multi-omics technologies, and I expect that in a few years we will have identified a number of new targets which specifically target the resistant leukemic stem cell in AML and hopefully also in CML and others. And actually this may open new trajectories and possibilities for novel therapies.